Welcome to eGurukul and DBMCI. Today we are going to discuss some very interesting clinical pharmacology MCQ from a very important topic in pharmacology, that will be anti-cancer drugs. So let us begin with this very interesting session. As I said, today's topic is anti-cancer drugs and we will discuss some very important, very interesting clinical scenario based MCQs. Before we begin, a brief introduction about myself. I am a pharmacology faculty, Dr. Arpit. I've been teaching pharmacology for over a decade now, both in India and to students studying abroad. Over all these years, I have had the fortune of interacting with thousands of students and helping them clear various competitive examinations. So I hope the audio and video is clear. Give me a thumbs up in the comment section if the audio and video is clear and there is no technical problem. Let me know. So we will begin now. First question on your screen. First question: clinical pattern pharmacology from anti-cancer drugs. Okay, and let us discuss the first question on our screen. Now we have a 50-year-old woman who complains of headache, nausea, vomiting. CT scan of the head reveals a large mass in the frontal lobe, and that mass is found to be a glioblastoma with the glioblastoma multiforme. So let me know, what do you think is the correct answer? Is it A, thalidomide, B, cisplatin, C, thioguanine, and D, temozolomide? Which of these is the correct option? Yes, everyone. Dr. Patel? Anyone? CNS tumor, which of these should be given? Thalidomide, cisplatin, thioguanine, temozolomide? Yes, everyone. All of you, I want maximum participation in these classes, these sessions. We conduct them to have more and more participation, so that we have a very lively session. So do not hesitate. Even if you are wrong, it's just a practice session. Do not hesitate. Tell me A, B, C, or D. I have one answer, cisplatin. The correct answer to this question would be option number D, temozolomide. That is the correct answer. That is the correct answer. So please remember, for CNS tumors, one class of drugs that is commonly used is called nitrosourea. Nitrosoureas belong to alkylating agents, and they include drugs like lomustine, carmustine. These are highly lipid soluble anti-cancer drugs, highly lipid soluble, so they easily cross blood-brain barrier and used for CNS tumors. But none of them is mentioned in the options. Another drug that is specifically used for glioblastoma multiforme would be our answer in this, temozolomide. So temozolomide is another alkylating agent which also has high CNS penetration and used for glioblastoma multiforme. And remember, temozolomide is having excellent oral absorption. So this is an orally administered anti-cancer drug used for CNS tumor, glioblastoma multiforme. So the correct answer to this question is option number D. Okay. So CNS tumors, most likely you will be asked about these two types of drugs: nitrosoureas, lomustine or carmustine, and temozolomide, which is specifically used for glioblastoma multiforme. Moving to the next question. So we will begin with simple questions, then we'll go to more complex ones, including the new anti-cancer drugs like antibodies. So let's look at the question number 2. Question number 2. A 65-year-old man, he presents with changes in bowel frequency. So he is having gastrointestinal disturbances, changes in bowel frequency with occasional bright red blood in the stool. Blood in the stool. Elderly men presents with blood in the stool. A CT scan reveals lesion consistent with metastasis in liver. So mets are seen in liver. Elderly men, blood in stool, changes in bowel frequency. Which cancer should you suspect? Which cancer should you suspect? Yes, anyone. Very important medicinal concept. In elderly men presenting with anemia or blood in stool, which cancer would you suspect? And what is the background therapy? What is the main therapy for that particular cancer? Yes. Yes, let me know which cancer would you suspect. In an elderly man presenting with blood in stool, liver has mets, colon carcinoma, that is very good. We are looking for colorectal carcinoma. Colorectal carcinoma should be our suspicion. Very common cause of anemia and blood in stool in elderly men. Colorectal carcinoma. Yes, Dr. Anshu, that is correct. Now please remember, for colorectal carcinoma, usually we give two kind of chemotherapies. Okay, either we can give FOLFOX regimen, FOLFOX therapy, or we can give FOLFIRI therapy. Two popular regimens are there for colorectal carcinoma. FOL always stands for folinic acid. F is the main drug for colorectal carcinoma, that is 5-fluorouracil. 5-fluorouracil, and ox can be added, which is oxaliplatin. Oxaliplatin. So this is a very popular therapy, FOLFOX, folinic acid, 5-fluorouracil, and oxaliplatin. If patient becomes resistant or non-responsive to oxaliplatin, or they cannot tolerate oxaliplatin, then what we can replace, oxaliplatin can be replaced by another drug, which you can see RII, and that is called irinotecan. Irinotecan is a topoisomerase type 1 inhibitor, which can be used in place of oxaliplatin. Rest of the two drugs remain same. So what is the main drug, background therapy for colorectal carcinoma? If you are asked one drug, then answer is F. F is the main drug, and therefore 5-fluorouracil is the correct answer. 5-fluorouracil is the correct answer. Please remember, this is the background, this is the main therapy for colorectal carcinoma. Folinic acid is a adjuvant given with 5-FU to increase its action. So folinic acid is given to increase the action of 5-fluorouracil, and oxaliplatin or irinotecan can be added. So these are the two therapies for colorectal carcinoma. Okay. Next question on your screen. A 50-year-old man was diagnosed with a testicular cancer. One of the drugs commonly used for this cancer could cause pulmonary fibrosis. What is that drug? So this question is a very interesting question. You have a man with the testicular cancer, and the drug that is used for treatment of this could cause pulmonary fibrosis. You are asked to identify that drug. So now you see, very interesting question. If I look at the option, cisplatin will not cause, it does not cause pulmonary fibrosis. Cisplatin is highly hematogenic. It can cause nephrotoxicity, ototoxicity, but not pulmonary fibrosis. Rest of the three drugs, all three drugs cause pulmonary fibrosis. All of them can cause pulmonary fibrosis. So we can rule out only option A based on this information. Now we have to apply this knowledge that testicular cancer out of these B, C and D, which is used in testicular cancer. So that is a memory based question and answer will be bleomycin, option number D. Option number D. Yes. Yes, Dr. Max, Dr. Kunj, Dr. Rahul, very good. Bleomycin fulfills both the criteria. It is used for testicular cancer and also causes pulmonary fibrosis. So answer is D. Busulfan and methotrexate can cause pulmonary fibrosis, but they are not useful in testicular cancer or not commonly used for treatment of testicular cancer. So that is why they will not be the correct answer. Okay. So I hope this is clear that you need to know both the important side effects and the important use. So bleomycin has two important uses. It can be used for testicular cancer and it can also be used for Hodgkin's lymphoma. These are the two important uses of bleomycin which are commonly asked, and side effects of bleomycin. So pulmonary fibrosis has been asked in this question, and the one more side effect that is very commonly asked is called as the flagellate pigmentation of skin. Flagellate pigmentation of skin. So that is another commonly asked side effect. That is what you want to know about bleomycin. Bleomycin causes pulmonary fibrosis used in testicular cancer. Okay. So next question. Next question on your screen. 60-year-old men complains of back pain. A CT scan demonstrates osteoblastic lesion of the lumbar spine. So there is a osteoblastic lesion in the lumbar spine. That is why he is having back pain. His prostate specific antigen are high. So PSA is high. So it is indicative that the patient is primarily having cancer of prostate. And from cancer of prostate, metastasis, mets have gone into the vertebral column, and that is why he is presenting with back pain. But actually is a case of cancer of prostate. Therapy with which agent is to be started? Cancer of prostate. Out of the given option, what will be the treatment? Okay, so now we have a lot of students joining. Okay, Dr. Kunj, Dr. Rahul, Dr. Moitra, anastrozole, leuprolide, tamoxifen, mitotane. Let me know, very important question. Cancer of prostate. Cancer of prostate. Which of these drugs can be used? Anyone? Mitotane. Mitotane is an anti-steroid. It inhibits the adrenal steroid synthesis. Mitotane. This will be used in cancer of adrenal cortex. Adrenal cortical carcinoma. So mitotane obviously is not the answer here. Everyone, please everyone, let me know what do you think is the correct answer. You see, that is very important, your participation, and we all learn from our mistakes. So even if we are wrong, it does not matter. This is not the exam. This is just us participating in this session, competing against ourselves only. So please let me know, everyone. So mitotane is not the answer. Tamoxifen. Tamoxifen is an SERM, selective estrogen receptor modulator, and the main use of tamoxifen is cancer of breast. This is a drug used in cancer of breast. So that is also not the answer. Not the answer. Okay. Dr. Renu says, Dr. Ranu says A. Anastrozole. Let's come to anastrozole. Anastrozole is an aromatase. aromatase inhibitor. And aromatase inhibitors are also mainly used for cancer of breast, particularly in post-menopausal female. Post-menopausal female, we give aromatase inhibitor for cancer of breast. Again, not the answer. So what is the answer? Answer is option number B. Option number B. Yes, Dr. Anju, very good, very good. So for cancer of prostate, we use GnRH. GnRH agonist can be used. We can use GnRH agonist given in continuous fashion. And GnRH agonist can be remembered as relin. Their names end with relin. Drugs like Gosa, relin, Nefe, relin. So GnRH agonists usually they end with relin, but we also need to remember there is a different name. There is a name which is not ending in relin, that is called leuprolide. So leuprolide is a GnRH agonist. GnRH agonist. When GnRH agonists are given in continuous manner, daily manner, they decrease the level of gonadotropins, that decreases testosterone, and that decreases prostate cancer. So goserelin, neferelin, buserelin, all relin are GnRH agonists, but leuprolide, a different name, is also a GnRH agonist, and that can be used for cancer of prostate. So that is the correct answer, leuprolide. So what is the learning here? क्या learning है इस question में? When we are studying anti-cancer drugs, we are clear what is anastrozole, what is tamoxifen, what is mitotane. But when we close the chapter, when we close our notes, then sometimes the prostate cancer appears similar to breast cancer, and drugs of breast cancer becomes confusing with prostate cancer. So unless we are sure that aromatase inhibitors, tamoxifen, these are drugs which are discussed in female hormonal system. They are not usually utilized for male cancer like prostate cancer. So that is the learning. So I hope everybody liked this question, and you got to understand the importance of remembering where do you study these kind of drugs. Anastrozole, tamoxifen, they are studied in female hormonal system. GnRH agonist can be used for both cancer of breast in females as well as cancer of prostate in males. So they can be used for both in females cancer of breast and in males cancer of prostate. So I would say very interesting question. Okay. So if you like the question, please do not hesitate to give a thumbs up. Yes, Dr. Tyagi, thank you. So many more questions. We are just at the third question. So many more questions are going to come up. Please continue to like the session and share it live with your friends. Okay, do not hesitate. Next question. Read the next question carefully. Now again you see prostatic cancer. To emphasize, we have again taken prostatic cancer and we have again taken leuprolide. So now you know leuprolide is a GnRH agonist. You know this now. So a 60-year-old male diagnosed with prostatic mass has begun on leuprolide, GnRH agonist. He returns to your office, that means your clinic, a week later, complaining that his urge to urinate has increased. So what we can see is increase in symptoms. Prostate is growing, whether carcinoma or non-carcinoma. It will compress the urethra, and therefore the urinary frequency, urgency, it will increase. So his symptoms have increased. What is the cause? So now you tell me. In the previous question, I told you what is GnRH agonist, what are the names, they are used for prostate cancer and breast cancer. Now to re-emphasize this particular fact and remember the important point, we have another question. अब इसमें एक 60 साल का मेल है प्रोस्टेट कैंसर का, ल्यूप्रोलाइड पे स्टार्ट हुआ है, एक हफ्ते बाद वापस आता है, कहता है डॉक्टर साहब माय सिम्टम्स हैव वर्सेंड, माय अर्ज टू यूरिनेट हैज इंक्रीज्ड, ये क्या हो रहा है, व्हाट इज द कॉज? सो नाउ यू टेल मी. Yes, I can see Rahul, Dr. Rahul saying C, Dr. Kunz saying C, Dr. Bhatt says B, Anchu says C, and Dr. Tyagi also says C. So now, tumor resistance to leuprolide, reduction of conversion of testosterone to dihydrotestosterone. This is done by finasteride, 5-alpha reductase inhibitor. Finasteride or 5-alpha reductase inhibitor, which are used in BPH, not in carcinoma. So this is not the answer. Prostatic resistance to leuprolide. Now you see option number D and option number A. They are same. Tumor resistance, prostatic resistance. So that means we cannot have this as the answer. So the correct answer is option number C only. Transient flare of the tumor symptoms. So we must know then when we give GnRH agonist, when we start the treatment, so initially for few days there is an initial side effect which comes, and that can be increased tumor flare up. So for few days initially GnRH agonist will cause this problem of tumor flare up, so patient symptom will worsen, and that is the correct answer, transient flare. And you must know that this tumor flare up, initial tumor flare up, is not seen, it does not happen with a related but different class of drugs that are called GnRH antagonist. GnRH antagonists do not cause this. So agonist cause it, antagonists do not. And can you tell me any GnRH antagonist used in prostate cancer? Can anyone tell me the name of GnRH antagonist which is used for treatment of prostate cancer and will not cause the initial tumor flare up? दो तरह की दवाइयां यूज होंगी, GnRH agonist जिसमें कि इनिशियल ट्यूमर फ्लेयर अप होता है, और दूसरी हो सकती है GnRH antagonist जिसमें ट्यूमर फ्लेयर अप नहीं होगा. So what is the name of that GnRH antagonist which is used in prostate cancer and therefore does not cause initial tumor flare up? क्या नाम है उसका? Yes, number of students live in the session is increasing, but number of answers is not increasing. Which is that GnRH antagonist used in prostate cancer which does not cause initial tumor flare up? Yes, Dr. Anjana, Dr. Ganesh, Dr. Moitra, yes, everyone. बताइए, याद कीजिए, दिमाग पे जोर डालिए, पढ़ा है आपको, वेरी वेरी इंपॉर्टेंट. अगोनिस्ट और एंटागनिस्ट में यही क्वेश्चन आता है. वेटिंग फॉर योर आंसर्स. ठीक है, पार्टिसिपेशन इज द की. अगेन एंड अगेन आई एम टेलिंग यू, आप हिचकिचाइए नहीं, डू नॉट हेजिटेट. नहीं आता है तो से नो, वी डोंट नो. आता है तो गिव मी द आंसर. तो आंसर विल बी हियर डेगा रेलिक्स. तो रेलिन, I told you in the previous question, relin are GnRH agonist, they cause tumor flare up. Relics are GnRH antagonist and they do not cause tumor flare up. That is what you have to remember, GnRH agonist versus GnRH antagonist in prostate cancer. Very very important point, and these points are regularly asked. ये दो क्वेश्चन, पिछले वाला और ये वाला, अगर आपने कर लिया, you will know everything that you need to know in GnRH antagonist versus agonist. तो चलते हैं नेक्स्ट क्वेश्चन पे, और नेक्स्ट क्वेश्चन हमारे सामने है. 67-year-old female being treated for rheumatoid arthritis with methotrexate. तो methotrexate एंटी-कैंसर ड्रग है. Also it is the preferred DMARD, best DMARD in rheumatoid arthritis. तो इसका क्वेश्चन rheumatoid arthritis में भी आता है. So we had a patient of rheumatoid arthritis. Methotrexate ले रही है patient. She was recently treated for a UTI, urinary tract infection, and has presented to hospital with pancytopenia. तो methotrexate ले रही है, MTX. Recently she developed a UTI and she received some drug for treatment of UTI, and now she comes with pancytopenia. Pancytopenia. Which medication most likely interacted with methotrexate to cause pancytopenia? बताइए, which of these? Trimethoprim, nitrofurantoin, ciprofloxacin, ceftriaxone. What is this treatment which has resulted in pancytopenia due to interaction with methotrexate? तो methotrexate क्या है? Methotrexate is a DHFR inhibitor. You all know DHFR inhibitor, dihydrofolate reductase inhibitor. This is required for synthesis of tetrahydrofolate and which is needed for DNA synthesis. So can you think of any other drug? Nitrofurantoin. नाइट्रोफिरेंटॉइन की अगर मेरे को प्रॉब्लम पूछनी होगी, साइड इफेक्ट पूछना होगा, आई विल ईदर आस्क पेरिफेरल न्यूरोपैथी. Most likely the problem that is asked with nitrofurantoin is peripheral neuropathy. Here, what will be the answer? The answer here will be trimethoprim. Answer is trimethoprim. The patient was receiving trimethoprim. Trimethoprim also, you know, is a DHFR inhibitor. So now what we have done, we have given two drugs which are DHFR inhibitor. So excessive DHFR inhibition occurs, excessive blockade of DHFR enzyme. So folate tetrahydrofolate is not formed, and tetrahydrofolate is required for DNA synthesis. That does not occur. Because DHFR is excessively inhibited. So folate active form of folate is not formed, FH4. DNA synthesis नहीं होगी, और DNA synthesis नहीं होगी तो bone marrow suppression. तो bone marrow suppression हो गया है patient को, because he was given methotrexate along with another DHFR inhibitor. Okay, that is the answer, option number A. नाइट्रोफिरेंटॉइन का क्वेश्चन आएगा तो पेरिफेरल न्यूरोपैथी पे आएगा. सिप्रोफ्लॉक्सासिन के साइड इफेक्ट पूछे जाएंगे अगर, तो टेंडन डैमेज टू टेंडन एंड सीजर इन एपिलेप्टिक पेशेंट, ये साइड इफेक्ट होंगे. सेफ्ट्राइक्सोन के साइड इफेक्ट या तो होगा एलर्जी या पूछेंगे गॉल स्टोन, biliary lithiasis, particularly in children, neonates. So remember, trimethoprim, DHFR inhibitor, like pyrimethamine, combined with methotrexate, excessive DHFR inhibition resulting in pancytopenia. Okay, so I hope you have now understood methotrexate का एक drug interaction, whether you are using as anti-cancer or you are using as DMARD. तो सबको क्लियर है? कोई कंफ्यूजन? आज थके हुए लग रहे हैं आप लोग. People are looking a bit tired, not answering very quickly like you do in all other sessions. Participation भी थोड़ा कम लग रहा है. So what is the reason? Please cheer up. Please gather some strength and let us look at this next question. 70-year-old man reports blood in the urine, lower abdominal pain, blood in the urine, hematuria, suprapubic pain, lower abdominal pain हो सकता है, suprapubic pain. He is also concerned about the urinary frequency urgency, urinary symptoms हो गए हैं उसको. He states that he recently completed a cycle of chemotherapy for non-Hodgkin's lymphoma. Which kind of treatment is most commonly used? Which drug is most likely responsible? Yes, Dr. Ganesh, very good. So patient non-Hodgkin's lymphoma के लिए लेता है commonly chalk therapy with or without rituximab. C stands for cyclophosphamide. Or cyclophosphamide, you all know, has a side effect of causing hemorrhagic cystitis. तो इसको ब्लैडर डैमेज हो गया है, hemorrhagic cystitis. उसकी वजह से हेमेचूरिया हो गया है, ब्लैडर एपिथेलियम इज डैमेज, सो हेमेचूरिया, दिस इज योर ब्लैडर, epithelium of bladder is damaged, hemorrhagic cystitis resulting in hematuria, lower bladder symptom, urinary urgency frequency, cyclophosphamide, and you all know for treatment of this hemorrhagic cystitis we have to give a substance called as Mesna. So that is the last question on this, Mesna, correct? तो ये है साइक्लोफॉस्फेमाइड का क्वेश्चन, वेरी सिंपल क्वेश्चन एंड मोस्ट ऑफ यू आंसर्ड इट करेक्टली, सो आई होप दिस इज वेरी वेरी सिंपल. CHOP थेरेपी इज यूज्ड फॉर non-Hodgkin's. साइक्लोफॉस्फेमाइड कैन कॉज हेमरेजिक सिस्टाइटिस, सिम्टम्स उसके दिए हुए हैं, ट्रीटमेंट उसका होता है मेसना. मेसना विल बाइंड एक्रोलीन, द मेटाबोलाइट रिस्पांसिबल फॉर ब्लैडर सिम्टम. अगले क्वेश्चन पे चलते हैं. अगला क्वेश्चन है non-Hodgkin's लिम्फोमा का दोबारा. 45-year-old non-Hodgkin's lymphoma, CHOP therapy ले रहा है. Now the full form is written. तो cyclophosphamide, hydroxydoxorubicin, H से होता है hydroxydoxorubicin. O is oncovin. Oncovin is the brand name of vincristine. And P is the steroid prednisolone. जिनको नहीं पता था अब उनको CHOP therapy का full form पता है. Now he complains of pins and needles in the legs. He has difficulty getting up from a chair, most likely causative agent. Yes, बताइए इसमें pins and needles, paresthesias हो रहे हैं उसको, difficulty getting up, most likely causative agent. क्या हो गया है इसको? Which side effect do you think? Yes, एक ही करेक्ट आंसर आया अभी तक डॉक्टर अंजना का. अदर्स ऑल्सो प्लीज. क्या हो गया इसको, क्या सिम्टम है? यस डॉक्टर रॉय, वेरी वेरी गुड. द पेशेंट इज हैविंग पेरिफेरल न्यूरोपैथी, and out of these the drug most likely to cause peripheral neuropathy is vincristine. Vincristine, that is the answer. That is the answer. Vincristine, you all know, is bone marrow sparing. It does not cause bone marrow suppression, but what it causes is peripheral neuropathy, and that is what this patient has developed. So answer is vincristine. Cyclophosphamide के साइड इफेक्ट we have already seen पिछले क्वेश्चन में. स्टेरॉइड के कोई खास साइड इफेक्ट होते नहीं है, एक्सेप्ट इन लॉन्ग रन दे कैन कॉज ऑस्टियोपोरोसिस एंड एचपीए सेपरेशन, कैटरैक्ट, बट वो लॉन्ग रन में होते हैं, कैंसर पेशेंट में नहीं होते जनरली. डॉक्सोरूबिसिन का साइड इफेक्ट अगर पूछा जाता है तो यू मस्ट नो दैट द ड्रग इज कार्डियोटॉक्सिक, कार्डियोमायोपैथी. दैट इज द साइड इफेक्ट आस्क्ड इन डॉक्सोरूबिसिन जनरली. सो यहां पे करेक्ट आंसर है विनक्रिस्टीन. विनक्रिस्टीन. तो अभी तक बहुत सारे हमने क्वेश्चन किए हैं, उसमें हमने क्या देखा है कि एंटी कैंसर में वन ऑफ द कॉमनेस्ट टास्क टॉपिक इज द साइड इफेक्ट ऑफ द ड्रग. अब साइड इफेक्ट जनरली हमको वन लाइनर पढ़ाए जाते हैं, दैट विनक्रिस्टीन कॉजेज पेरिफेरल न्यूरोपैथी, डॉक्सोरूबिसिन कॉजेज कार्डियोमायोपैथी, साइक्लोफॉस्फेमाइड कॉजेज सिस्टाइटिस. बट क्लिनिकल पैटर्न में क्या हमको समझना है कि पेरिफेरल न्यूरोपैथी कैन प्रेजेंट एज मेनी फॉर्म्स. One of the form written in front of you, paresthesias, pin and needle sensation. Hemorrhagic cystitis can present as suprapubic pain, hematuria. तो ये है क्लिनिकल पैटर्न जो आपको समझना होगा कि पेशेंट आएगा तो किस चीज की कंप्लेंट लेके आएगा, एंड देयरफॉर व्हिच सिम्पटम शुड रेज अ सस्पिशन ऑफ एनी साइड इफेक्ट इन आवर माइंड. तो आई होप ये क्वेश्चन आपको समझ में आ रहे होंगे. नेक्स्ट क्वेश्चन पे हम चलते हैं. अब कुछ नए क्वेश्चंस लाते हैं. नए मींस न्यूअर एंटी कैंसर ड्रग्स. ऑल आर ड्रग्स टारगेटिंग HER2/new receptor. All are drugs targeting HER2/new receptor. Trastuzumab, Lapatinib, Pertuzumab, Pembrolizumab. Tell me. Newer cancer antibodies, new pattern. New pattern of MCQ also, you can see 4 drugs are given and you have to tell me whether one is causing, two is causing, all of them are causing, or combination of these drugs is causing or targeting HER2/neu. I hope you all know HER2/neu. Drugs which target this receptor are used for the cancer of breast. तो बताइए, Dr. Balaji says A, Anjana says A, Anshu says A. So very quickly I'll tell you how to remember. This is a cancer of breast cell. On this there is a receptor. This receptor is HER2 HER type 2/neu receptor. Now what happens when this receptor is stimulated? Whenever this receptor is stimulated, two receptors form a dimer. Two such receptors come close to each other and they will form a dimer. So two receptors will join, form a dimer. Once they form the dimer or dimerization, then what happens? That intracellularly inside the cell, this receptor is a tyrosine kinase. Alone, this tyrosine kinase is inactive, negative. Tyrosine kinase is not working. But when dimerization happens, when receptor is stimulated and receptors form dimer, then this tyrosine kinase activity becomes active. This tyrosine kinase becomes active, and when this becomes active, it will cause growth of this particular breast cancer cell. That is the flow of events. Now what we have done, please see what we have done. We have developed an antibody against the receptor. We have developed an antibody against this receptor which will go and block this receptor. So receptor will not be stimulated. This antibody is called trastuzumab. So trastuzumab is an antibody against this receptor. HER2/neu, it blocks the receptor. Receptor is not stimulated. The next we have developed is an antibody which will prevent dimerization. Antibody which is going to prevent dimerization. Dimerization inhibitor. That antibody is called pertuzumab. So pertuzumab is also against HER2 receptor, but it is preventing dimerization. And lastly, we can inhibit this tyrosine kinase activity of this receptor by giving drugs such as lepatinib. So lepatinib is also targeting HER2/neu receptor, but it is not blocking the receptor. It is preventing the tyrosine kinase activity of this activated receptor. So trastuzumab is targeting HER2/neu, lepatinib is targeting HER2/neu, and pertuzumab is also targeting HER2/neu. So answer is option number A. Option number A. So I hope it is clear to everyone. Drugs targeting HER2/neu. Trastuzumab, pertuzumab are antibodies. Lepatinib is an oral tyrosine kinase inhibitor. All of them are used for breast cancer patients who are positive for HER2/neu receptor. So I hope with this diagram you will be able to remember drugs targeting HER2/neu receptor in breast cancer for all. तो ट्रास्टुज़ुमैब कहाँ बाइंड कर रही है, पर्टुज़ुमैब और लेपाटिनिब, ये आपको क्लियरली है विजिबल इन दिस पर्टिकुलर डायग्राम. तो अगर क्लियर हो तो गिव मी अ थम्स अप. समझ में आ गया हो कैसे द ड्रग्स आर टारगेटिंग द सेम रिसेप्टर बट देयर बाइंडिंग साइट्स आर डिफरेंट. ये आपस में अलग अलग दवाइयां हैं बट यूज सबका सेम है, HER2 पॉजिटिव ब्रेस्ट कैंसर पेशेंट. तो अगर समझ में आया हो, मजा आया हो तो गिव मी अ थम्स अप. ठीक है, चलिए नेक्स्ट क्वेश्चन पे चलें. एवरीबॉडी इज क्लियर? चलिए, थैंक यू डॉक्टर अपू. अब देखिए ब्रेस्ट कैंसर को एक बार हमने टॉपिक को लिया. अब ब्रेस्ट कैंसर में और क्या क्या क्वेश्चन आते हैं फार्माकोलॉजी में उसको समझने की हम कोशिश करेंगे. जैसे हमने प्रोस्टेट कैंसर को समझा था. आफ्टर कीमोथेरेपी A breast cancer patient was found to have a high pulse rate. तो ब्रेस्ट कैंसर का पेशेंट है, कीमोथेरेपी मिल चुकी है, पल्स रेट अब हाई है. A radionuclide scan revealed cardiomyopathy. The drug that is most likely responsible. ये तो सबको आता होगा, मैंने पिछले क्वेश्चंस में बताया भी था. कार्डियोमायोपैथी, कार्डियोमायोपैथी कौन सी ड्रग करेगी इनमें से? सो tamoxifen, methotrexate, doxorubicin, cyclophosphamide. दो चीजें जरूरी हैं, ब्रेस्ट कैंसर में यूज हो ड्रग और कार्डियोमायोपैथी करे. ये तीनों ड्रग्स कैन बी यूज्ड फॉर ट्रीटमेंट ऑफ कैंसर ऑफ ब्रेस्ट. tamoxifen also for cancer of breast, but mostly ये होती है हार्मोनल थेरेपी. तो इसको कीमोथेरेपी जनरली नहीं लिखते हैं, हार्मोनल थेरेपी लिखते हैं. बट ये भी कैंसर ऑफ ब्रेस्ट में हो सकती है, बट ये कीमोथेरेपी नहीं लिखते हैं, इसको हार्मोनल थेरेपी लिखते हैं, अगेन फॉर ब्रेस्ट कैंसर. अब इसमें से कार्डियोमायोपैथी विल बी डन बाय डॉक्सोरूबिसिन. कई बार हमने बात की है डॉक्सोरूबिसिन, एंथ्रासाइक्लिन. अब याद रखिए डॉक्सोरूबिसिन इज आल्सो नोन एज एड्रियामाइसिन. एड्रियामाइसिन और डॉक्सोरूबिसिन इज द सेम ही ड्रग है. एड्रियामाइसिन ब्रांड नेम है डॉक्सोरूबिसिन का. इनका साइड इफेक्ट क्लियर है, डायलेटेड कार्डियोमायोपैथी. डायलेटेड कार्डियोमायोपैथी which can result in congestive heart failure. तो अगर इसको आपको प्रिवेंट करना है, you want to reduce it, so we give an iron chelator. Yes, already Dr. Anjana has told us that iron chelator which reduces this cardiomyopathy is called dexrazoxane. Dexrazoxane आयरन चिलेटर है. आयरन चिलेटर, आयरन चिलेट करता है, लेस आयरन, लेस फ्री रेडिकल, लेस कार्डियोमायोपैथी. ये लॉजिक है. लेस आयरन, लेस फ्री रेडिकल जनरेशन, लेस कार्डियोमायोपैथी caused by doxorubicin. So याद रखिएगा कार्डियोमायोपैथी doxorubicin and what is given for treatment dexrazoxane iron chelator. Iron chelator. Yes डॉक्टर अप्पू, सिंपल क्वेश्चन था, सबको आता था, वेरी गुड. नेक्स्ट क्वेश्चन. अब देखिए उसी क्वेश्चन को थोड़ा सा और, अब हमने HER2, ब्रेस्ट कैंसर, कार्डियोमायोपैथी तीनों को मिला दिया. ब्रेस्ट कैंसर, HER2 और कार्डियोमायोपैथी. अब बताइए 50-year-old woman with history of MI and CHF. तो कार्डिक हिस्ट्री है पेशेंट की. She is treated with ramipril, aspirin, atenolol. Diagnosed with HER2 positive breast cancer and recommended for chemotherapy. Which drug carries the least risk of cardiotoxicity and therefore best suited for her? अब आप बताइए. तो देखिए इस क्वेश्चन में हमने कैंसर ऑफ ब्रेस्ट के साथ मिक्स किया HER2 रिसेप्टर को और साथ में कार्डियोटॉक्सिक साइड इफेक्ट. तो ये तीनों चीजें आपको आनी चाहिए और पिछले 3 क्वेश्चन में हमने इन्हीं की बात को रिलेट करने की कोशिश करते हैं. तो टेल मी बेस्ट सूटेड फॉर हर, लीस्ट कार्डियोटॉक्सिक. तो नाउ यू सी this drug we have discussed is going to cause cardiomyopathy. अभी पिछले क्वेश्चन में हमने किया. Trastuzumab is a drug against HER2, correct? Drug for breast cancer, correct? Is it cardiotoxic? Yes, this is also cardiotoxic. This also causes cardiomyopathy. Pertuzumab, drug against HER2 receptor used in breast cancer, also causes cardiomyopathy. So now you can see option number A, B and C. All are used in breast cancer. All are cardiotoxic. All cause cardiomyopathy. So which is best suited? Paclitaxel. Paclitaxel. Paclitaxel का मेन प्रॉब्लम अगर आप देखेंगे साइड इफेक्ट, नंबर 1, एक तो ये ड्रग इट इज यूज्ड इन ब्रेस्ट कैंसर. Paclitaxel is used for breast cancer. Paclitaxel की साइड इफेक्ट है या तो हाइपर सेंसिटिविटी, या फिर इट हैज पेरिफेरल न्यूरोपैथी। आपने नाम सुना होगा ग्लव एंड स्टॉकिंग, ग्लव एंड स्टॉकिंग पैटर्न ऑफ न्यूरोपैथी। ग्लव्स पहनते हैं जहां स्टॉकिंग पहनते हैं, डिस्टल न्यूरोपैथी होती है पेक्लिटेक्सेल के साथ। पेक्लिटेक्सेल, तो पेक्लिटेक्सेल causes neuropathy not cardiotoxic, so paclitaxel is not cardiotoxic and therefore best suited to this patient जिसको ऑलरेडी CHF की हिस्ट्री है, तो we would like to avoid cardiotoxic drug, तो A, B और C you should avoid। therefore another way of asking the same thing कि अगर patient HER2 positive है and you want to give trastuzumab, तो trastuzumab के साथ you should add, if needed you can add paclitaxel because paclitaxel is not cardiotoxic, and trastuzumab के साथ you should not add doxorubicin because doxorubicin like trastuzumab is cardiotoxic। तो क्लियर है, तो do not add doxorubicin, do not add doxorubicin because it is cardiotoxic, add paclitaxel with trastuzumab, paclitaxel is not cardiotoxic। तो आई होप ब्रेस्ट कैंसर के क्वेश्चंस आपको क्लियर हो गए होंगे। कार्डियोटॉक्सिसिटी किसमें है किसमें नहीं है, HER2 पॉजिटिव की ड्रग्स कौन सी हैं, पेक्लिटेक्सेल की क्या इंपॉर्टेंस है, ओके, pertuzumab, trastuzumab are also cardiotoxic। ये आपको नया इंफॉर्मेशन इस सेशन में मिली होगी। आई होप कि मजा आया होगा आपको और आप अब बिना किसी फर्दर रिवीजन के इन पॉइंट्स को याद रख पाएंगे। अगर ऐसा है तो द सेशन इज सक्सेसफुल if I can contribute to even one question extra correct in your exam, then these sessions are successful। That is the aim, that is our aim at eGurukul, to be a partner, to be just a platform to ensure that you all succeed, all of you succeed, that is our aim। okay, तो चलिए नेक्स्ट क्वेश्चन पे। नेक्स्ट क्वेश्चन, a patient on cisplatin, he develops intractable vomiting on third day of the treatment। So we all know cisplatin is highly hematogenic, and we call this property as chemotherapy induced nausea and vomiting, CINV। सबको पता है chemotherapy induced nausea and vomiting most likely cause is cisplatin। drug of choice for controlling this vomiting बताइए तुरंत। I want everybody to answer, जब तक सब आंसर नहीं करेंगे मैं आगे जाऊंगा ही नहीं। CINV is such an important topic। Patient on cisplatin developing vomiting on the third day of the treatment, most likely the treatment given is drug of choice for controlling this, बताइए सब। I can see only Dr. Appu, Dr. Ganesh and Dr. Anjana answering, everybody else there are 25 students। बाकी भी प्लीज, metoclopramide, prochlorperazine, ondansetron, aprepitant, कौन सी ड्रग देनी है इसमें, थर्ड डे की क्या इंपॉर्टेंस है, CINV दो फेजेस में होती है वॉमिटिंग, कीमोथेरेपी इंड्यूस्ड नोजिया एंड वॉमिटिंग। एक्यूट फेज मींस इमीडिएटली, ड्रग देने के विदिन आवर्स, within 1 to 2 hours of taking the drug। Acute phase, patient will start vomiting, you have to give 5-HT3 antagonist like ondansetron, pelonosetron, but there is a delayed phase also, delayed phase of vomiting that will start after 2 days। तो पेशेंट को आपने cisplatin दिया, within hours he will start vomiting, वो एक्यूट फेज है. आफ्टर अ डे पेशेंट विल डेवलप टॉलरेंस, वॉमिटिंग विल सबसाइड, वॉमिटिंग धीरे धीरे कम हो जाएगी, बट तीसरे दिन ही वॉमिटिंग वापस शुरू हो सकती है. डिलेड फेज. And best drug that we considered for delayed phase is a neurokinin 1 antagonist. Neurokinin 1 antagonist, and that is called aprepitant. Aprepitant. Rolapitant. All these patent. Substance P antagonist है ये. न्यूरोकाइनिन 1 इज द रिसेप्टर ऑफ सब्सटेंस पी, उसको ब्लॉक करते हैं, आर मोर यूजफुल इन डिलेड फेज ऑफ CINV. सो यहां पे आंसर होगा एप्रीपिटेट. जस्ट बिकॉज थर्ड डे इज स्पेसिफिकली आस्क्ड इन एग्जाम. अगर ये थर्ड डे नहीं होता, डे नहीं होता, ही डेवलप्स वॉमिटिंग, दैट्स ऑल. एंड ड्रग ऑफ चॉइस, सिर्फ CINV की ड्रग ऑफ चॉइस पूछी है, कोई डिटेल्स नहीं दी है. तो अगेन 5-HT3 एंटागोनिस्ट लाइक ondansetron, pelonosetron will be the answer. So ये है CINV की कहानी, एक्यूट फेज, डिलेड फेज, ओवरऑल. नेक्स्ट क्वेश्चन. 56-year-old men complaints of fatigue and malaise. WBC count is dramatically elevated. Chromosomal studies indicate a 922 translocation, Philadelphia chromosome. तो क्लियर है Philadelphia chromosome. क्या डायग्नोसिस है Philadelphia chromosome? What is the diagnosis? डायग्नोसिस क्या है? डायग्नोसिस बन गया इसका CML, Philadelphia chromosome positive CML. और CML की ड्रग ऑफ चॉइस क्या है? We all know imatinib. A tyrosine kinase inhibitor is the drug of choice in CML. So ये सिंपल क्वेश्चन था, सबको पता है. Rituximab नहीं डॉक्टर मुत्रा. Rituximab is mostly used for non-Hodgkin's lymphoma. Gefitinib is mostly used for non-small cell lung carcinoma. So answer is imatinib. Simple. 922 means Philadelphia chromosome, means CML, means imatinib is the drug of choice. Next question. Now we have just gastrointestinal stromal tumor refractory to imatinib can be treated by. So again, very important question. Imatinib is drug of choice. Number 1 for CML, also for gastrointestinal stromal tumor. Okay, दो जगह imatinib is drug of choice, CML and gastrointestinal stromal tumor. अब अगर रेजिस्टेंस हो, रेजिस्टेंस टू इमेटिनिब, तो सेकेंड लाइन ड्रग्स का रोल आएगा. तो अगर CML में इमेटिनिब की रेजिस्टेंस है तो वी विल लुक फॉर DNB. क्या देखेंगे आप? DNB, डेसाटिनिब, नेल्यूटिनिब, बोसुटिनिब. तो DNB, dasatinib, nelutinib, bosutinib, these are used if imatinib resistance is there in CML. But if you have resistance in GIST, then go to a drug called sunitinib. So that is what you have to mug up. Sunitinib is the drug of choice if GIST becomes refractory to imatinib, the first line drug. Nilotinib, bosutinib, dasatinib, DNB is used if there is resistance in CML. If there is resistance in GIST, then sunitinib is a very good drug, sunitinib. So answer here will be sunitinib. And please remember, sunitinib is also mainly, it was developed for renal cell carcinoma. So sunitinib is mainly or initially developed for renal cell carcinoma, Nowadays, it is also used for GIST, which is refractory to imatinib, and it is also used for pancreatic cancer. So these are uses of sunitinib: renal cell carcinoma, GIST, and pancreatic cancer. So these are very important drugs, very important MCQs. So CML refractory, DNB, GIST refractory, sunitinib. So आई होप ये क्वेश्चंस आपको बिल्कुल क्लियर होंगे, कोई कंफ्यूजन नहीं होगा और ये आप लंबे समय तक अब याद रख पाएंगे. टायरोसिन काइनेज इनहिबिटर्स और फर्स्ट लाइन ट्रीटमेंट इन. तो नई दवाइयां हैं टायरोसिन काइनेज इनहिबिटर. कई नाम हमने याद किए: इमैटिनिब, सुनिटिनिब, जेफिटिनिब, डेजाटिनिब, निलोटिनिब, बोजुटिनिब. All nib are tyrosine kinase inhibitor and all of them are oral. All of them are oral. तो किसमें फर्स्ट लाइन ट्रीटमेंट आपको आना चाहिए? अब तो आना चाहिए आपको फर्स्ट लाइन ट्रीटमेंट. इन सब में यूज हो सकते हैं. ओके, इन सब में दे कैन बी यूज्ड. बट फर्स्ट लाइन ट्रीटमेंट किसमें है? फर्स्ट लाइन ट्रीटमेंट किसमें है? दिस यू शुड बी एबल टू टेल मी. टायरोसिन काइनेज इनहिबिटर्स आर फर्स्ट लाइन ट्रीटमेंट इन. तो देखिए, जस्ट गैस्ट्रोइंटेस्टाइनल स्ट्रोमल ट्यूमर. जिस्ट इज अ कीमो insensitive tumor. The only drug that are available for GIST is tyrosine kinase inhibitor. Other conventional drugs are not effective for GIST. Only tyrosine kinase inhibitor, which I have told you, the best drug to start the treatment is imatinib. And if patient becomes resistant to imatinib, you can go to sunitinib. You can go to sunitinib. तो फर्स्ट लाइन ट्रीटमेंट टू स्टार्ट इसमें है. बाकी टीके इनहिबिटर्स आर यूज्ड इन ऑल अदर्स आल्सो. आई जस्ट टेल यू, हेपेटोसेलुलर कार्सिनोमा में वी कैन यूज सोराफेनिब बट नॉट दी फर्स्ट लाइन ट्रीटमेंट. ब्रेस्ट कैंसर में ऑलरेडी वी हैव डिस्कस्ड लेपार्टनिब. बट पहले कीमोथेरेपी दे सकते हैं आप, डॉक्सोरुबिसिन, पैक्लिटेक्सेल. Likewise, then you can go trastuzumab, then you can go AML में you have the isocitrate dehydrogenase inhibitors, evacitinib. They are new drugs. AML का भी फर्स्ट लाइन ट्रीटमेंट नहीं है ये. So they can, tyrosine kinase inhibitor आज प्रैक्टिकली हर ट्यूमर के लिए अवेलेबल है. But their drug of choice, first line drug, best to start treatment in GIST. Why? Because GIST usually is a chemo insensitive tumor और कोई दवाई GIST में एक्ट करती नहीं है. Okay, so that is a very important piece of information. Next question आता है आपके सामने. 36-year-old man, fever हो गया उसको, infection, epistaxis. Blood examination reveals elevated WBC. क्रोमोसोमल स्टडीज में हो गया ट्रांसलोकेशन 15 to 17, वेरी इंपॉर्टेंट. नहीं भी दिया हुआ डायग्नोसिस तो आपको आना चाहिए. ट्रांसलोकेशन 15-17, इंडिकेटिंग एक्यूट प्रोमाइलोसिटिक ल्यूकेमिया. सो AML के कई टाइप हैं, M0 से लेके M7 तक. सबका ट्रीटमेंट स्टार्ट हम करते हैं साइटोसिन एरेबिनोसाइड से. All of them M0 to M7, all AML will be treated with cytosine arabinoside except M3, which is also called as promyelocytic leukemia, translocation 15 to 17. M3 के अंदर क्या यूज करते हैं हम? M3 के अंदर यस अपू विनय, वेरी गुड, अट्रा, ऑल ट्रांस रेटिनोइक एसिड, खाली अट्रा, या वी कैन ऑल्सो एड आर्सेनिक ट्राइऑक्साइड. सो M3 में if you give cytosine arabinoside in M3, then there is a risk, there is a side effect of disseminated intravascular coagulation. तो M3 में हम cytosine दे सकते हैं, we can, but there is a risk of disseminated intravascular coagulation. So we do not, therefore we do not give cytosine arabinoside in M3. What we give is a combination of all trans retinoic acid with or without arsenic trioxide. So that is the correct answer in this particular question. The answer is option number C. Option number C. Option A, cytosine arabinoside या cytarabine आंसर नहीं है. Why? Because in M3, if you give cytarabine, there is a risk of disseminated intravascular coagulation, तो वो नहीं प्रेफर होगा. तो आई होप डॉक्टर मोहित्रा ये कंफ्यूजन आपको क्लियर हो गया होगा कि AML में M3 इज अ स्पेशल टाइप. ओके, चलिए आगे. 40-year-old male presents with fever, chest pain, respiratory same. He was recently diagnosed with a blood cancer and put on induction therapy. तो ब्लड कैंसर का पेशेंट है, इंडक्शन थेरेपी लिया था, अब आया है फीवर, चेस्ट पेन और रेस्पिरेटरी डिस्ट्रेस लेके. एक्सरे किया तो बायलैटरल प्लूरल एफ्यूजन, पल्मोनरी इन्फिल्ट्रेट पेरिकार्डियल एफ्यूजन, pleural and pericardial effusion, classical side effects. It was diagnosed to be a complication of his anti-leukemic treatment. Drug likely responsible. उसी क्वेश्चन का सेकंड पार्ट है ये. We are looking at a case of acute myeloid leukemia. Which type? M3 type, PML. For treatment of M3, we have discussed that we will give all trans retinoic acid. When we give all trans retinoic acid, it causes a side effect called as differentiation syndrome. It causes differentiation syndrome. Capillary permeability increases in differentiation syndrome, and that causes pleural effusion and pericardial effusion. So this is differentiation syndrome due to tretinoin. So this is differentiation syndrome caused by all trans retinoic acid. तो M3 के अंदर हम अट्रा दे रहे हैं, ये हमने लास्ट क्वेश्चन में सीखा, और इस क्वेश्चन में हमने सीखा जब हम अट्रा देते हैं तो क्या साइड इफेक्ट एक्सपेक्टेड है. डिफरेंशिएशन ऑफ कैपिलरीज अकर्स, permeability of capillaries increases, pleural and pericardial effusion can occur. Cytosine arabinoside, which is used for all except M3, bone marrow suppression उसका साइड इफेक्ट है, and cerebellum damage, ataxia, dyskinesia, nystagmus, ये cytosine arabinoside के साइड इफेक्ट हैं, which is used in M0 to M7 except M3. तो अट्रा का क्या साइड इफेक्ट है, साइटोसिन के क्या साइड इफेक्ट है, कब किसको यूज करना है, वो सारा हमने पढ़ लिया. तो AML हमने पढ़ लिया, CML हमने पढ़ लिया. These are the important points in blood cancers. So that is all. आज के सेशन में इतना था हमारे पास टू डिस्कस. हमने डिस्कस किया साइड इफेक्ट्स ऑफ कॉमनली यूज्ड एंटी कैंसर ड्रग्स क्लिनिकल प्रेजेंटेशन के साथ. हमने डिस्कस किया न्यू एंटीबॉडीज, टायरोसिन काइनेज इनहिबिटर्स कहाँ यूज करते हैं, क्या उनकी मेन टॉक्सिसिटीज हैं. देन वी डाइवर्टेड आवर अटेंशन टू सम ल्यूकेमियाज जो इंपॉर्टेंट है, CML, AML, उनके क्या टाइप्स हैं, किस में कौन से ड्रग प्रेफर करेंगे, उनके क्या साइड इफेक्ट्स हैं, किस तरीके से प्रेजेंटेशन होती है, क्या पॉइंट्स हैं जो हमको याद होने चाहिए. तो दीज आर द इंपॉर्टेंट पॉइंट्स फ्रॉम एंटी कैंसर. अगर आप ये जो क्वेश्चंस हमने किए हैं, इफ यू विल रिवाइज देम, then I am very hopeful. एक तो आपके concept हमेशा के clear होंगे, and secondly, a lot of these points will come in your upcoming examination. So with that, I am Dr. Arpit saying good night. I hope you enjoyed these sessions. If you did, please subscribe to the channel, hit the bell icon so that you get the timely notification, and also do not forget to like the session and share it with your friends. Okay? So thank you all for joining, And I'll see you next week with yet another important topic in pharmacology in a clinical pattern to make you exam next ready. Thank you.